obviously Australia's had a history where it's almost a part of the social compact that healthcare, education, a strong and retirement. They're almost kind of expectations that that Australians have that that they've held for a long time, and these are free institutions in a lot of ways, things that are very highly accessible. The idea of universal healthcare, that is this idea that healthcare should be free to pretty much every Australian, is that an idea or an ideal that's basically dead in Australia right now? I mean, is it something that is no longer affordable?
I think Professor Duckett will talk on this, but look, in any good country, you look after the poor and the needy. And Australia, in many ways, is still a lucky country, still a fortunate country. We should be able to look after the poor and needy. So I think it'd be a very sad day if we did away with bulk billing.
So I'm going to be in Canberra tomorrow and at the National Press Club, where a book is being launched because tomorrow is the 50th anniversary of the election of the Whitlam government, the government that ushered in Medibank, which subsequently became Medicare. Australians love Medicare, partly because it gives us choice of which doctor we go to, partly because for most people, 2/3 of all Australians are bulk billed for all of their general practice visits. And Australia doesn't spend a lot of money on healthcare. If you look at it compared to other wealthy countries, we're in the middle range. So we've got a system that works and we've got access for most. The problem is, as I said, not for everybody. So I think there's no reason to say we can't afford it. We've just got to spend our money wisely and make sure we're investing in the right areas.
Kylie, did you have any thoughts on that?
Yeah, that's really exciting that tomorrow's that 50th anniversary, and John Deeble, who's the patron of our Deeble Institute for Health Policy Research, and when you sort of think back to, he was one of the people who was the co-architect of Medibank and then Medicare. We do a lot of, I guess, reflection on what it was that he was driving for, and it certainly wasn't saying Medicare as I have designed it. His real drive was seeing people who had cancer who couldn't afford treatment and saying that's not acceptable. And I think that's when we think about Medicare, we need to be tied to that in terms of how do we reform, not be tied to Medicare as the way that it was designed back in the beginning. So I think, looking at how do we shift away from the current way of doing things requires taking into consideration things like who is doing what and how are we funding for it. And I think we're seeing a lot of that transition happening, whether it's through the Independent Health and Aged Care Pricing Authority and the work they've done to look at, well, how would you fund differently and for which conditions would be a good place to start exploring, funding people who have, I think the care pathways that they're looking at, the people who have chronic and complex disease, activity-based or fee-for-service payments are not the right way to fund to incentivise good outcomes. And similarly, it's people who have a consistent care pathway. So it might be someone who goes through, knee replacement through to rehabilitation. It's a fairly standard pathway for each patient. So how would you fund for that to, again, incentivise, the right care being given to the person at the right time?
Yeah, and look, I'll jump in here as well. I think, the idea of bulk billing, which obviously in the past has been where the patient rebate is effectively being used as the payment that the practices accept as, as full payment. That obviously assumes that the practice is happy to accept that payment to cover all their costs. I think the difficulty here is that, and for those who aren't aware, I'm a GP and a practicing one as well. And a lot of my colleagues certainly have felt that in an environment where the indexation of Medicare has not actually met the escalating costs of delivering quality healthcare in general practice, and also, I guess, the blunt instrument that looks a lot like a level B consult that is just around about $30 of rebate to cover the standard consult. The cost of operating a practice in Toorak is not going to be the same as operating a practice out in the Northern Territory as compared to what it might be in outer metro in, say, Perth. These are all very different cost bases, I guess, to deliver the same sort of care. And yet the Medicare rebate is by and large the same no matter where you go. And so the effective ability to balance up cost with what patients can afford, these are the things that sometimes GPs themselves have to wear. And the idea that they have to now sometimes be gatekeepers, not just for the healthcare system, but also for whether people are eligible to get bulk billing, and these sorts of things become quite difficult. So this is where I suppose the interface between human services and the eligibility for things like bulk billing and access to free healthcare, which is, you know, seen as a right for everyone versus it's a affordability thing and access thing for those who can't afford it, or, you know, who seem to be less advantaged when it comes to their economic situation. How do we actually find that, you know, that change that expectation perhaps from the public, where those who can afford to pay should pay privately and have some out-of-pocket costs potentially to help the sustainability of the healthcare system, and identify those who genuinely are in financial need to actually give them the ability to access healthcare without facing huge out-of-pocket costs? What can we do about that? Professor Duckett, do you have any
Yeah, so Marcus, I totally and completely disagree with the premise there. I mean, the whole point of Medicare and Medibank was it was a universal scheme. That is, it replaced the old highly targeted schemes. And I'll just give you a story. One of my first jobs was working in a public hospital in Sydney, and I was the acting revenue officer, and I had to take people to court because they couldn't pay their hospital bills. These were not pensioners; these were people just above the income cutoffs. And so Medibank was designed and always designed to be universal. So we shouldn't think about Medibank as being something for the poor people or whatever with Medicare. We've got to think about Medicare as being universal. And also, wealthy people already contribute to Medicare more than poorer people because they pay more income tax. The question is, how do we make sure Medicare and its rebates are fair for general practitioners so that, you know, they're not forced into this very difficult situation of saying, look, we want a bulk bill, but the rebates haven't gone up in line with average weekly earnings. They've gone up in line with CPI, but not in terms of the cost of running a practice. So I think, you know, we've got to think differently. My own view is we should have an independent fees tribunal which says this is a fair fee for what we're trying to do, and we shouldn't ask GPs, for example, to freeze their government should not freeze fees and say to GPs, well, I know your costs are going up, but your rebates are not, and we don't care, and we expect you to bulk bill. You know, we've got to be fair to both the providers and the consumers, and we can afford to be.
Professor, do you think the fee or the rebate should be postcode adjusted?
I think Marcus's point is absolutely right. When Medibank and Medicare were first introduced, we had different rebates for different states, which is a bit of a crude measure. But certainly, I think we've got to recognise different cost structures that practices face.
I certainly support your idea of an independent, panel or body to assess the fair fee. It takes the politics out of it, and as long as they're suitably qualified, hopefully no one would complain. I'm sure they would.
I think the other issue is that, and it's certainly something that no doubt you're discussing at the Strengthening Medicare Task Force, is this idea that fee-for-service and activity-based funding that a lot of hospitals, I guess, have adopted. Kylie, you mentioned the idea of moving to values-based healthcare, which tends to be more outcomes-based. I do wonder, is that something that's likely to be coming sooner rather than later? The changing mix of how Medicare was delivered from fee-for-service to the concept of healthcare homes and these types of things where it was more capitated and, it was more on a population basis. These are all concepts that have been put on the table, but it's pretty much gone quiet. So is that something that we're likely to see come back as part of the discussion?
I think it really needs to come back as part of the discussion, and I guess I'm hopeful, given the expansion and objectives and the name of the Independent Hospital Pricing Authority, to expand its remit to health and aged care as well. It's because I think one of the challenges you have, if you look at if you're funding the system in silos, you're going to get shifting of and not incentivize care in the right way. Similarly, if you're thinking about funding different health professionals under multiple different mechanisms and approaches, again, you're going to not have aligned incentives to actually give patients the best care. So I think there's some good work that we can build on, but it does need to be thinking about that full care pathway when it looks at it. And I think the other thing that needs to be thought about is, and as it's been alluded to already, those shifts in financial risk or in risk more generally in shifting to value-based payment models. It's not something that can be introduced overnight. It shouldn't be done in silos. There needs to be sort of a comprehensive framework or plan in place that steps out the shifts that are going to happen. You know, we've got to accept that we may not get it right first time, but that we're shifting towards an approach so that people can adjust their business models, we can mitigate some of these risks and not put it again back on providers just to accept all the risk that comes with that.
Yeah, I agree with that. So, Medibank was designed in the mid-1960s. Healthcare looks nothing like the mid-1960s. Both the diseases that are more prevalent and also the way practice, the growth of corporate practices and so on. So it's totally different. And yet our fundamentals of the fee arrangements and the payment arrangements haven't changed. So what you've got to step back and say, okay, let's look forward to sometime way into the future, 2050, for example, or 2040. What proportion of a general practice income ought to be fee for service? Because fee for service has some strengths. What proportion ought to be on some sort of per patient per month basis? And what proportion ought to be incentives for improved outcomes? And the answer to that in 2040 or 2050 is not going to be as it is now. So the question is, where do we want to get to, and over what time frame is it that we want to get there? And I think that's the issue for policy.